Center, Dr. Parvati Dutt. And before I begin, our gratitude to the brain behind the MDNMSR activities, our dear patron, Dr. V.P. Piley. And before I introduce, before I introduce the experts for today, I welcome the distinguished officials. Only Dr. Kunjumuddin has joined. And I have Dr. Sujitra, Dr. Subhash Malya, they have all agreed to join. Dr. Sujitra, the president of Kfog, again, very active in all the activities. Dr. Subhash Malya, the general secretary, Dr. Ajit, the state coordinator, and Dr. Kunjumuddin, I welcome you to today's webinar. Now, coming to introduction of our distinguished guests, we have Dr. B. Prasanna Kumari. She needs no introduction. MDNMSR is a subcommittee under Safe Motherhood Committee chaired by our stalwart in the field, Prasanna Madam. I'm happy that I have Madam as the chairperson for the wholehearted support that I received with her vast knowledge and also because of her intense desire to reduce preventable maternal deaths to zero. The author of a wonderful book in postgraduate gynecology, I needn't explain to the Kerala gynecology crowd about the great teacher in her. And our guest expert of the day, Dr. Sibu Matthew, he is at present the professor of cardiology at GMC, Government Medical College, Trivandrum. And he is the convener of the standard treatment guidelines in cardiology in Kerala. I should say that we are all going to be benefited by his expert opinions. And I hope at the end of the session, we have a very clear picture of pulmonary artery hypertension and mitral stenosis for the take-home knowledge. And now comes our dear Dr. Sangeeta Menon, well known to the state as well as the national gynecology crowd as a great orator who literally lives through her sessions. She's involved with the maternal mortality reduction activities and the various training programs associated. She's a member of the State Medical Council unit and vice chairperson of the Board of Studies of Kerala University of Health Sciences. Now we have our Dr. Beena Kumari. She's the professor and head of the Department of Gynecology at Government Medical College, Kottayam. In addition to being an excellent teacher, good academician, she's a great reader and has up-to-date knowledge in obstetrics and gynecology. She takes part actively in our discussions and enriches us with very valid points. And she is actively involved in the training programs also. Now we have Dr. Parvati Dutt, the young and vibrant presenter for today. She is a senior consultant in ONG, Devi Hospital, Tripunithura. When I say she is the editor of Kfog Journal, I need not tell you how updated she is. She is the vice captain of MDNMSR Ernakulam district and is an active member of Kfog with many, many extracurricular activities. And with this, I invite Dr. Parvati Dutt for presentation of the cases.
Good evening, respected seniors and dear colleagues. Without wasting time, I'm moving on to the first case. That's a 27-year-old primary gravida who presented at 35 weeks, 3 days with abdominal pain suggestive of preterm labor. She became near-miss on the same day as the admission and got discharged on the 17th day of admission in HTU. Diagnosis made at the time of admission was primary gravida, 35 weeks, 3 days in preterm labor. Going to the history of the patient, she was married for 4 years, spontaneous conception, uneventful antenatal period, and had 2 antenatal visits in the same institution where she reported now. She was appreciating good fetal movements, and her BMI was 21, and her general and systemic examination were normal at the time of presentation. Now, the obstetric examination revealed a uterus size of 34 to 36 weeks, cephalic, presentation with good fetal heart rate, and there were contractions lasting for 25 seconds every 3 minutes. She had a late preterm vaginal delivery, that is at 35 weeks, 2 days, with RMLE after 1 hour after admission, and it was a male baby of weight 1.93 kg. She was being monitored in the postpartum ward. Then she developed shivering about 3 hours after the delivery. At that time, she was febrile but conscious and oriented. She had a tachycardia of 132 beats per minute with a BP recording of 130/70, and the respiratory rate was 42 with a SpO2 of only 38% in the room air. And the chest auscultation revealed no basal crux. So there was tachycardia, tachypnea, saturation fall. So the possible diagnosis which came to our mind was amniotic fluid embolism or pulmonary embolism. Oxygen inhalation was given, injection hydrocortisone 100 milligram IV, injection darafilin 100 milligram IV, and the patient was seen by the anesthetist who did a bedside echo and revealed that there is right atrial and right ventricular dilatation. Retrospectively, when we asked the patient's relatives about any of the symptoms, they said that she had complaints of dyspnea on exertion since the past 7 years, which got aggravated in the previous 3 weeks. 1 hour later, her pulse rate was 130 beats per minute with a BP of 140/80. Respiratory rate was still 42 with the SpO2 of 84% with 10 liter O2. The cardiology consultation was done. They also repeated the bedside echo, which revealed right ventricular dilatation, moderate TR, moderate PAH, good LV/RV function. They made a diagnosis of Cori acute pulmonary embolism, Cori TR with acute decompensated heart failure. The patient was advised injection heparin 5,000 units international unit stat followed by 1,000 units hourly. The patient was put on NIV and emergency CTPA was done. About 40 minutes later, the patient was still on NIV, pulse rate of 124, BP of 140/80, respiratory rate came to 38, with the SpO2 of 82%, FiO2 100%, PEEP 5. The chest auscultation revealed was clear and CVS was NAD. Per abdomen, the uterus was well contracted and retracted.
പാർവതി
മാഡം കേക്കാവോ?
ഇപ്പൊ അല്ല കേട്ടില്ല, ഇടയ്ക്കൊരു ബ്രേക്ക് വന്നു.
ഇപ്പൊ കേക്കാവോ മാഡം?
കേൾക്കാം.
കാണാൻ പറ്റുന്നില്ല, ഒരു മിനിറ്റ് മാഡം, ഞാൻ വായിക്കാം, എനിക്ക് വീഡിയോ വരുന്നില്ല എന്നേ ഉള്ളൂ. ഞാൻ വായിച്ചോട്ടെ, കേൾക്കാവല്ലോ അല്ലേ മാഡം? About and the per abdomen, the uterus was well contracted and retracted, and bleeding PV was within normal limits, even though we started her on heparin. A CT pulmonary angiogram was done, which showed the main pulmonary artery was grossly dilated, with the right and the left pulmonary artery dilated. The features were suggestive of pulmonary artery hypertension. There was no evidence of pulmonary embolism, and the blood investigations showed no gross abnormalities. A detailed echo was done. Madam, am I audible?
Yes, you are.
The detailed echo showed that the right atrium and the right ventricle was dilated. The pulmonary artery, main right and left were dilated, and a diagnosis of severe pulmonary artery hypertension was made. The chest X-ray showed cardiac enlargement, and the USG chest showed right side lung B lines anteriorly, left side B lines anteriorly and posteriorly. The venous Doppler showed no evidence of BVT on the bilateral lower limb Doppler study. The pulmonologist suggested to continue NIV. The patient was started on injection ceftriaxone sulbactam combination. Metrogyl was given along with injection Lasix and enoxaparin of 40 units sub-Q. Started on sildenafil and combination of ambrisentan and tadalafil. Seen by a rheumatologist, no abnormality detected. Patient was monitored in HDU and NIV for 4 days. Changed to O2 mask later. Patient was transferred to cardiology on postnatal day 9. Patient improved and discharged on postnatal day 16 from the cardiology after explaining all the risks. So the final diagnosis was primary, 35 weeks, late preterm delivery, severe pulmonary artery hypertension. It came in the category of 1.2, that is pre-existing disorders aggravated during pregnancy. That is, disorder was cardiac and the aggravating factor was PAH. The near-miss criteria, the symptoms and signs, that is tachycardia, tachypnea, saturation fall. Investigation showed abnormal echo, and intervention there was NIV. Hello?
Parvati, you can continue. Experts ne vilikam. Cardiologist ki thodangiyalo.
Yes, madam.
Dr. Sibu Matthew.
Madam,
a good case for discussion. So
Yes.
this patient, this particular patient actually had 2 antenatal visits, and probably the patient was asymptomatic, definitely. Otherwise, we would have evaluated. So even the pregnancy and delivery was tolerated well. She had, I mean, a preterm vaginal delivery, but patient did not have any problem at the time of delivery. And in the 3 hours after the delivery, only the problem started. There are certain oddities in the presentation. One, the patient at the time of the problem, she had shivering, and then she had tachycardia, and the BP is 137. In a patient with pulmonary hypertension, when the patient goes in for a problem, that is because of severe pulmonary hypertension, which means that the RV output is low or RV fails, the BP of 130/70 is not that expected. Usually the BP is on the lower side.
Outside.
And I mean, I am discussing the oddities. And the SpO2 of 38%, I think that that SpO2 is very unlikely to be a real SpO2 in a patient who is conscious and oriented, because 38% SpO2 is very, very, very low. So when a patient is shivering, and when the patient has got peripheral vasoconstriction, when the finger probe is not well placed, the saturation probe may not be picking up all you may get a very low SpO2 values. So that 38%, I think it may not be a reliable value. But at the same time, in a significant pulmonary artery hypertension, a BP is expected beyond the lower side. So 2 things. One, the patient did not have much problem. A patient who is having class 3 or 4 symptoms, that is patient having symptoms even on mild activity with significant restriction of activity or symptoms at rest. That is a thing which suggests a significant problem. Patient functional class 1 or 2 probably may not be having much problem. Second, a patient with pulmonary artery hypertension, when there is a significant cardiac output at the time of delivery, or when there is a uterotonic agents or other agents which are used to, which may produce increase in the pulmonary vascular resistance, all these situations can precipitate a problem, but patient actually tolerated the delivery, the cardiac output. So generally, I would think that the patient did not have significant pulmonary artery hypertension. So it was a surprise that subsequently in the echo, there was a significant pulmonary artery dilatation and severe PAH. So that is a little odd. We expect the patient to be more symptomatic and the BP to be on the lower side, patient to have some clinical signs like loud P2, as well as pulmonary artery pulsations in the left second space and left parasternal heave. These are the symptoms, the clinical signs of pulmonary artery hypertension. These were not there. So it is actually tough on the gynecologist side to pick up these things, because when this patient is not having symptoms, so it is surprise. But then the patient had echo showed severe pulmonary echo, as well as a subsequent CT showed significant pulmonary artery dilatation. Patient had significant RA-RV dilatation and pulmonary artery hypertension. So there are certain oddities, but pulmonary artery hypertension being a very significant cause of maternal as well as fetal morbidity as well as mortality is a very serious condition. Even though it is not a very common situation, it is a very serious situation which can result in significant worse outcome in the maternal side as well as fetal side. And if significant pulmonary artery hypertension is diagnosed prior to in the early part, or even prior to pregnancy, a pregnancy advice against pregnancy or even a termination of pregnancy may be advised in the early part. Here, the patient had an uneventful pregnancy. Probably it was can it be a febrile illness or chills and rigor which precipitated all these events? That is what I am thinking. Probably the low SpO2 was because of very low SpO2. Subsequently, the SpO2 was around 80% or 90% or something like that. So what was the SpO2 at the pre-evaluation stage? I mean, the time when the patient was coming for the regular antenatal checkup, was it normal, or do you routinely check SpO2?
No, sir. Usually when she is admitted in the first stage of labor, when we check the basic vitals, usually we check the SpO2. That's all. Not during the antenatal visits in the OP, we don't check the SpO2.
Because SpO2 is now can be an easy way of evaluating patient's cardiovascular status. SpO2 being very simple method, a finger pulse oximetry can be used. Just like BP, pulse and saturation also can be monitored in all patients. Because sometimes in a patient who is having a minimal desaturation, where cyanosis may not be picked up clinically, this may be helpful. So we can actually include SpO2 as our regular practice in the clinical practice in the checkup of all patients. That is, I am suggesting SpO2. Sometimes when you pick up a SpO2 less than 90%, okay, this patient, we cannot have a detailed cardiac evaluation for all patients. So probably this may be one thing which can add to our clinical evaluation.
Okay, sir. Point well taken, sir. We'll note it.
Sir, I have a doubt in this patient, if I may ask. The echo really did not show any pulmonary hypertension at all. It's the CT angio that picked it up. So usually if there was such a severe degree of pulmonary hypertension with this degree of arterial dilatation, wouldn't that have been picked up on the echo? And with
Echo,
this
it was
severe-
there. It was there,
Echo, it
Sangeeta.
was there, madam.
It was there. It was there.
Oh,
In
actually,
echo also it was there.
echo as well as CT actually does not pick
Sure.
up pulmonary hypertension directly, because there is no way of assessing pulmonary artery pressure by echo. It is only indirect evidence. You get
Evidence.
right atrial
Yes,
as well
yes.
as right ventricular dilatation, a tricuspid regurgitation, pulmonary artery hypertension, pulmonary artery dilatation. But we will not get pulmonary artery pressures. We are getting indirect evidences. In CT
Yes.
also, we will get dilatation of these structures, that is pulmonary artery, RA and RV. If we are really in doubt, even in the antenatal period, we may go for a direct measurement of the pulmonary artery pressure by cardiac catheterization when we are really in doubt. PAH has to be diagnosed by pulmonary artery catheterization when there is doubt.
Because as you
So
said,
echo-
it seems so unlikely that such a severe degree of pulmonary hypertension has withstood labor and she has escaped from being a mortality as well. Usually
No,
these women tend to,
yes, yes.
can it be a primary pulmonary hypertension?
Yes, Sangeeta, it was a case of primary pulmonary hypertension. She didn't have any cardiac lesions.
Yeah,
Or
but then throwing
echocardiography also.
to tolerate
Uh,
pregnancy to 36 weeks and to deliver with a primary pulmonary hypertension, is that
She had a history of exertional dyspnea. That's what it was.
yeah, 7
He was rheumatic
For
since
7 years, she was having exertional dyspnea. So the problem is that she didn't come out with it, and some patients maybe on only on asking the history positively by leading questions, then only they will come out. So
Madam, what is the degree of pulmonary artery hypertension we will have to evaluate subsequently after a few weeks or even months? Because when the patient is having, maybe patient was having only moderate pulmonary artery hypertension or on the lower side, and because of the increased volume overload and during pregnancy, there was a chamber dilatation of the chambers as well as the pulmonary artery, which may settle down a little once the hemodynamics or the volume status settles. So we don't know whether the pulmonary hypertension was really severe to begin with. But as the pregnancy advanced, there was chamber enlargement, and as the volume increases, the pulmonary pressures also will increase.
No, here nothing has been mentioned regarding whether any methergine or prostaglandins were given to the patient, because sometimes in patients with rectal prostaglandins, they develop shivering after delivery.
Prostaglandins are generally contraindicated if you know pH, significant pH.
Yeah, because we never knew this was a case of heart disease.
Madam. Yes, madam. Yes, madam.
That is one thing, because that has not been mentioned in the history.
And oxytocin also can be given, but only in very low dose. That is what is.
So anything which is causing hypotension should be avoided like that, no?
Here,
but she never had hypotension.
Never had
He
hypotension.
never had hypotension. That is actually a odd finding, as sir said. She never went in for hypotension. So that was the one which was against pulmonary embolism or amniotic fluid embolism, which when there is tachycardia, tachypnea, usually all these things will be associated with hypotension when we suspect an amniotic fluid embolism or pulmonary embolism. and no history of PPH or any coagulation abnormalities also was described in the case. So that's why routine cardiology anyway we will be doing. So RARV dilatation, the pulmonary embolism was the second, the first possibility. So they have proceeded with the CTP, and then it was found to be a primary pulmonary hypertension. That's what is mentioned.
So I suspect the pH was only moderate or lesser on the lesser
It is
side.
moderate. It is moderate only. But otherwise, severe pH, I don't think the patient will be asymptomatic throughout.
Asymptomatic. And only the volume overload produces this much dilation.
Yeah. Yes.
Can a lung disease produce a pulmonary artery hypertension?
Yes, madam. All these things, she has undergone
Yes.
she has undergone a pulmonary evaluation also, because interstitial lungs disease are known to produce pulmonary artery hypertension, and also the connective tissue disorders. So they have done a rheumatology consultation also.
Ultrasound
Yes.
is also normal.
Ultrasound sound is also
and
normal.
Continue, Dr. Beena.
Yeah. Usually, primary pulmonary hypertension is the diagnosis here. That should be all the other cases, like the common pulmonary hypertension, which we see is from the rheumatic heart disease, mainly mitral stenosis, and also the reversal of shunts, Eisenmenger syndrome. That is the commonest pulmonary artery hypertension, which we usually see. But there can be other causes also, like as you said, madam, interstitial lung disease, connective tissue disorders, HIV infection, chronic thromboembolic disorders. All these things can cause secondary pulmonary artery hypertension. So these patients usually will not withstand the normal hemodynamic changes in the pregnancy. Usually the pulmonary artery system is a low pressure system, less than 20 millimeters of mercury. So it can accommodate so much of blood. So this 40% rise in blood volume in normal pregnancy, they will not be able to withstand. But she gives history of exertional dyspnea. Maybe if we had spent a little more time with the patient and found out this history, this cardiac evaluation would have been done earlier.
Yeah,
Prasanna,
7
madam?
years. 7 years she's
7
had
years.
this problem.
Yes.
Prasanna, madam?
So what I have to say at the outset is that each and every antenatal patient comes. The first obstetrician who sees the patient should take a proper history. This patient definitely gives a history of 7 years of exertional dyspnea. And they should have completely taken the history. All history we have to take when the patient comes. All this history suggestive of any symptoms, and then the family history. For example, congenital anomalies. We have methods of prenatal distinction. So complete history should be taken. That is my advice to every obstetrician. Complete history and complete examination. In this complete examination, definitely, if the patient had primary pulmonary hypertension, which is confirmed, she would have definitely had some loud and split second sound, a bruit in the pulmonary area, and things like that. Definitely. And we should have a very low threshold for referring to cardiologist.
Yes.
Even if it may be a third heart sound, but we should refer the patient to the cardiologist to do an echo and find out what exactly the patient has abnormality in the cardiovascular system. And as Dr. Sibu Matthew said, noting the oxygen saturation, it can be easily done in the antenatal OP. So if it is possible, better do it. Or at least when the patient is admitted in the labor room, even if she's a low risk patient. And this patient, actually, she can go in for problems in the after delivery, third stage or fourth stage of labor, because all the circulating volume will increase. And as we teach our undergraduates, even if she has not gone into failure or discomfort during labor, she can go into problem after delivery. And another thing is, if we have evaluated the patient earlier, then of course, any heart disease, it should be any serious heart disease, there should be a multidisciplinary meeting And a care plan should be made for each patient, and name of the person caring the name of the cardiologist, name of the obstetrician, name of the anesthesiologist, everything should be written in the care plan, and she should be given a care plan, and this care plan should be exhibited in the labor room. We had a patient with cardiomyopathy. We made a care plan and we communicated to everybody else, but the patient finally got referral to Amrita Hospital, and there she had a cesarean. We were planning her cesarean here in Lifeline Hospital, but she went on herself. So my advice is that, and this patient, because this picture can occur, as already said, in the case of amniotic fluid embolism or pulmonary embolism. But in that case, my doubt to the cardiologist is, in that case, will there be this much of right atrial and right ventricular dilatation that is possible? I thought that is possible only in primary pulmonary hypertension.
Madam, acute dilatation of RA, RV are commonly seen in acute pulmonary embolism, and that is one of the features we suspect by doing echo. So acute pulmonary embolism, we see RA, RV dilatation, but the thing is that PA pressures are not significantly elevated. PA also are not that much dilated. PA pressures are not significantly elevated because it is only acute rise. So acute dilatation of RA, RV can. And there are certain echo signs also which suggest acute pulmonary embolism in the RV, but we're not going to that. It can happen.
Here the sir, one doubt. So we cannot say that it is a primary pulmonary hypertension, right? Only after cardiac catheterization only can we say that it is primary pulmonary hypertension.
No, pulmonary embolism is reasonably ruled out because CT pulmonary angiogram did not show any significant thrombus. So pulmonary embolism is almost ruled out. Then the other causes of pulmonary artery hypertension, there are other causes. One, secondary to pulmonary hypertension can be a primary pulmonary hypertension, which includes a pulmonary artery hypertension, includes Eisenmenger syndrome like things also. Then pulmonary artery hypertension due to left heart disease. It is not there. Echo is done.
It is not there. It is not there.
Pulmonary artery hypertension due to respiratory problem. A pulmonary CT is done and pulmonology evaluation, it is also excluded. Then causes, other connective tissue disorders, other causes are also excluded. So for all practical purpose, this is a pulmonary artery hypertension, maybe a primary pulmonary hypertension or a shunt lesion, but echo has excluded a shunt lesion. So ultimately, it will be a primary pulmonary hypertension from the available data.
Dr. Sibu, supposing we have diagnosed this pulmonary hypertension the first time when she came, by your evaluation, you have done an echo or whatever investigation possible, and we have diagnosed primary pulmonary hypertension. How would you have managed this patient? Can you tell us something about
okay, one decision is regarding continuation of pregnancy. So that aspect we have already discussed because pulmonary artery hypertension has got high birth events in maternal as well as fetal. So we have to discuss and take a shared decision regarding the risk, and termination also we have to consider. But once that is not the situation where the person wants to continue pregnancy, we have to be really careful. One thing is that we have to monitor the patient. Some patients may be having only mild pulmonary artery hypertension to begin with, but as the volume increases, the patient can go into significant features of RV dilatation or increased pulmonary artery pressure. So we have to monitor the patient, and the frequency of monitoring depends upon the initial pulmonary artery hypertension. If the pulmonary artery hypertension is very severe, probably we may have to monitor more frequently, or at least once every trimester, or probably towards the end, every month we'll have to do the echo and evaluate. So we will have to correct any anemia. We have to avoid hypoxia, avoid hypercapnia during the procedure, during the delivery, or any acidosis, or anything which can increase pulmonary vascular resistance. Anything which can increase pulmonary vascular resistance should be avoided, including drugs as well as metabolic problems. And we have to anticipate RV dysfunction. We have to avoid excess fluid overload. We have to anticipate that. So it should be and very severe pulmonary artery hypertension should be the delivery should be in a center where facility for resuscitation and including probably ECMO is available. That is probably not
Yes,
available
yes.
in most of our centers. So, so we have to plan the delivery. And certain drugs may be useful for reducing pulmonary artery hypertension. So there are drugs like sildenafil, which is not that effective, phosphodiesterase inhibitor, which can be safely done. Other drugs like ambrisentan, bosentan, which we use in routine pulmonary artery hypertension, is not to be given in pregnancy because they are not recommended. Then nitric oxide and other prostacyclin analogs, which are extremely costly, and I not even use myself certain drugs and pulmonary hypertension specific drugs because of their cost and lack of availability. So whatever available in our center probably will be a sildenafil or phosphodiesterase inhibitor, which can be used as a drug to reduce pulmonary artery pressures. So that can be considered. In certain patients, when we think that there may be some risk of embolism or some element of pulmonary embolism or thrombosis, which is contributing to pulmonary artery hypertension, we may even give anticoagulation.
Yes.
Otherwise, we give phosphodiesterase inhibitors and monitor and manage volume status. And then the mode of delivery, it is a decision taken by the, again, probably a combined team discussion. And I understand that even though different textbooks are saying that vaginal delivery can be done safely, with some centers do cesarean section also.
Pulmonary artery hypertension, sir, the literature says that the mode of delivery should be by elective cesarean section. And the preferred anesthesia is epidural anesthesia, because that will not cause a sudden hypotension or a, under GA there is a high BP variation, like a sudden hypertension during the time of intubation. That is what they say.
What I read regarding that, and I don't know, I am not an expert in this because I just read, because epidural anesthesia and epidural and as well as a passive descent of the head and assisted delivery is the best way, because that produces less fluid shift. That is what they say, because the cesarean section produces more fluid shift and blood loss and other things. It is associated with more thrombogenicity. And sometimes we may have to convert to GA. If GA is done, ventilation is done, then the pulmonary vascular resistance can go up, intrathoracic pressure can go up. I don't have experience in that line, but that is what I read. So many textbooks say that cesarean section is the preferred way. Cesarean section is the preferred way, but some literature says that this way also is a good option. I don't know.
Maybe mild PAH with NYHA 1 and 2, they can tolerate. As this patient, she didn't have any problem
Yes.
regarding the vaginal delivery of the patient. So it maybe it depends upon the what is a functional class of the patient. Maybe NYHA 3, 4 may have more serious complications and maternal mortality. Actually, presence of pulmonary arterial hypertension comes in WHO class 4. That means the various literature says that the mortality can be up to 25%.
Yes.
Pulmonary artery hypertension. So
our ESC guidelines say that only for very selected cases you go for cesarean section. All others you go for advice. I don't know. That is
vaginal delivery.
Vaginal delivery.
Because the complications at cesarean section and vaginal delivery, both of them will have a sudden push of fluid and release of the compression after delivery. So the volume on the heart will be much more after that. In addition, you have, as Sir said, the thrombogenicity that is associated with the cesarean section. And even per se, pulmonary embolism could be an antecedent event prior to a pulmonary hypertension. That could have been the cause. But in this patient, the CTPA did not show anything at all. And as Madam said, if you had seen her in the first trimester, maybe we would have suggested a termination. But she sailed through her pregnancy and her normal delivery without any problem. And it just caused a shivering to push her, or maybe the shivering was also a physiological chill that normally happens. But it was 3 hours after her delivery, not immediately after. And I think what Madam had said, that history taking, we always ask, as we teach undergraduates, we say, do you have diabetes, hypertension, tuberculosis, asthma, epilepsy? It's good to ask drug allergy. It's also good. I always think it's a good thing to ask them, do you have anything to tell me? Were you normal as a child? Do you have any problem that you think the doctor should know? ശ്വാസമുട്ടലുണ്ടോ തലക്കറങ്ങി വീഴാറുണ്ടോ when you ask them these kind of things, they think, and if you tell them, you ask them specific things, diabetes, hypertension, they'll say no. But do you have anything to tell me? Have you ever been uncomfortable as a child? Were you normal? Did you play, run around with the rest? Did you have any problems? Now do you have any problems? I think that's a very important thing. And somebody had asked a very pertinent question: for all cases of dyspnea on exertion in the pregnant period, will you ask for an echocardiogram? I think I would, unless she, has some problem like anemia, which I know I have to correct. If she has none other, no hypertension, nothing else, and just has dyspnea on exertion, I would ask for an echo. And echo is also important when you deal with older age patients, when you deal with older age patients who've had IVF and with multiple pregnancies. With severe hypertension, I think you must do a echocardiogram as well.
We have
Eh,
to, we should have a
I-
very low threshold for referring to the
Yes,
cardiologist.
yes. No, where the most important thing is when you diagnose such a condition, she should be referred to a tertiary care center as where there is a critical care and cardiology department is available.
Diagnosed
because
pulmonary hypertension definitely should be in a
yes,
tertiary center.
they will they should deliver in a tertiary care center.
And I think we must all take Dr. Sibbu Matthew's suggestion very seriously, that even in the antenatal OP, it's just a question of putting the probe onto her finger and recording her SpO2 as well. I think that's a good system.
Yes.
And when
Sir was there.
the
Wanted to
saturation
talk
can be
something.
false.
Sorry, madam.
When the patient is shivering, the saturation which is picked up can be false, no?
Yes.
Yeah, that is also a possibility. Yes, that's a
that-
possibility.
Yes, but madam, subsequently also the
It was only
saturation was
40.
always 80s and 85s. So that means that patient had a problem. So a
Yes.
saturation probe could have picked up the situation in the pre-delivery phase itself, probably. I don't know.
Shekharan, sir.
Yeah, I was very carefully listening. Our cardiologist has given a very good take-home message, that is, it is so simple and important to use a pulse oximetry. It will give, I think, the pulse rate also as well as the oxygen saturation. And that will give a clue for taken as a screening for any cardiovascular disease. So just a screening, you may not pick up a fine murmur or so, but this will tell us that there is something wrong with it and we'll be careful. So that is an important point for all of us. And also we must take the history properly, and also making the physical examination, we must auscultate the heart. Many cases of very obvious murmur is also missed only when we see, when she develops problem, when we pick up all those things. So it's a must to have physical examination. Auscultation of the chest is an important part. Without that, we are not making any justice to the patient. So these things are to be kept in mind. Once we have conquered something like the PPH and other things, now these cases are coming, and we have to conquer these also to reduce the preventable deaths during delivery and other complications. We have to pick up all those things. So very nice presentation, very well discussed, and I picked up so many points. I was only having some doubt regarding, already the pulmonary artery is dilated, and still why we are giving sildenafil?
Pulmonary artery is dilated because of so many reasons. One, there is pulmonary artery hypertension, and now there is a volume overload. This volume overload of pregnancy might have produced an excessive dilatation, which may even come down later. So we give sildenafil to reduce pulmonary vascular resistance. Well, the resistance may not be in the main pulmonary artery; it is in the capillary level or the small vessel level. Pulmonary artery dilatation is the proximal pulmonary artery which is dilated. So pulmonary capillary resistance or the arteriolar resistance, not capillary, arterial resistance will come down.
Okay. It is something may be useful. It's a good adjective for that. Anyway, addition. Thank you.
Before we go into the next case, I request other faculties have joined. Dr. Ajit. Ajit, are you there? You want to say something about the case? അജിത്ത് ഇടയ്ക്ക് ഒന്ന് കൈ പൊക്കിയായിരുന്നു. Dr. Lalitambika, have you joined? See, I don't know whether chat is enabled or not. I had requested Dr. Kunjumoideen to make the delegates chart enabled. So he made a suggestion. There is some other option for question answer. So if you have some doubts, you can put it in the question answer session. We'll be able to read that. Okay.
Madam,
And,
few questions had come up regarding this case.
Okay. I saw only one question, and Dr. Beena, if you could see the questions, you
No,
can
I
say.
can't. Let me see.
Three questions are there.
Okay. And one thing, Dr. Sujitra Sudhir, the Kfog president, was there right from the beginning. She sent me a message. ഞാൻ പട്ടണത്തിലെ ഭൂതം പോലെ ആയിപ്പോയി, എനിക്ക് നിങ്ങളെയൊക്കെ കാണാം, നിങ്ങൾക്ക് എന്നെ കാണാൻ വയ്യാന്ന്. I think now she has opened the camera. Sujitra madam.
Yeah.
ഞാൻ കണ്ടു, ഇടയ്ക്ക് I saw you.
I had joined in my laptop. അതിലാണ് ഞാൻ പട്ടണത്തിന് ഭൂതമായി പോയത്. I could see everyone, I could hear everyone, but nobody was here. ഞാനുണ്ട് എന്നൊക്കെ പറയുന്നുണ്ടായിരുന്നു, പക്ഷെ nobody could hear. Anyway, Lakshmi Ammal, it's a very nice discussion. എനിക്ക് പല പ്രാവശ്യവും patients after delivery, they start shivering violently. ഭയങ്കര പേടിയാവും, പക്ഷെ നമ്മൾ പിന്നെ എല്ലാവർക്കും ഇപ്പൊ എക്കോ ഒക്കെ ചെയ്ത് റെഡിയാക്കി വെക്കുന്നുണ്ട്. Prevention is better than cure എന്ന് പറഞ്ഞ പോലെ. And that SPO2 during antenatal visits, I think it's a very good idea.
Yes,
So,
yes, yes.
wonderful.
Yeah.
പിന്നെ ലക്ഷ്മി അമ്മാൾ ഒരുപാട് കാര്യങ്ങൾ ചെയ്യുന്നുണ്ട്. Really appreciate her dedication and her എന്താ പറയണ്ടേ persistence.
No, please, madam, that's my duty.
അങ്ങനെ
Okay.
duty is, when you do your duty, it is a beauty എന്ന് പറഞ്ഞ നമ്മളെ
Okay,
അബ്ദുൽ കലാം.
Lakshmi
madam.
madam വായിക്കട്ടെ. Should we do echo for every woman with dyspnea on
madam,
exertion pregnancy? അത്
Sangeeta
പറഞ്ഞു.
answer
അത് പറഞ്ഞു. How do we differentiate AFE and pulmonary hypertension? That also we discussed.
Yes.
Had we diagnosed PPH antenatally, then when DA should be considered delivery, that also we have discussed. How do we classify pulmonary hypertension severity? And what is the lower limit of SpO2 allowed in patients with pulmonary hypertension? അത്രയാണുള്ളത്. So how do we classify pulmonary hypertension?
Pulmonary hypertension, okay. Pulmonary hypertension is defined as a hypertension when you when the mean pulmonary artery pressure is more than 20, then we will say that there is pulmonary hypertension. So for that, actually we have to have a CAT data, but we are getting indirect evidence based on the echo. We look at the tricuspid regurgitation and tricuspid regurgitation velocity. So generally, we classify pulmonary artery hypertension into a mild phase when the peak pulmonary artery pressure is 35 to 50 and moderate 50 to 70 or more than 70. So looking at the pulmonary artery pressures on the TR, we can classify it to mild, moderate, and severe. The problem is, even if we diagnose mild pulmonary artery hypertension in the first trimester, it can progress to significant pulmonary artery hypertension situation as the pregnancy progresses, because there can be fluid changes, and as the cardiac output increases, the pulmonary artery pressures can increase. So a person can have, with a moderate pulmonary artery hypertension, the person can have features of severe pulmonary artery hypertension towards the term. So it is sometimes unpredictable, even when a moderate pulmonary artery hypertension is present. So any pulmonary artery hypertension actually is considered to be a very high risk situation. Severe pulmonary artery hypertension to begin with, definitely. That is one part. Second, the SpO2, any SpO2 less than 90 is definitely abnormal. So I think that if the SpO2 is less than 92, and especially if you can ask the patient to walk, if the SpO2 is less than 92, ask the patient to walk a little, or if it is on the borderline side, and if the SpO2 is falling, that is definitely an indication that this person is having a problem. So SpO2 of less than 92, you should be very careful, and we have to do further evaluation. Probably there may be a right left shunt associated with SpO2 less than 92. So any SpO2 less than 92 will be uncomfortable.
Okay, that's a very nice point. The discussion is over. Can we go on to the next case?
Yes, ma'am.
Dr. Sangeeta, you want anything else to add?
No, not at all.
Okay. Prasanna madam, can we go to the next case?
Yes, we will go to the next case.
Madam, shall I start?
Prasanna madam?
Yes. And we will go to the next case.
Okay.
Okay. Shall I read, Lakshmi Ammal, madam?
Yeah, തീർച്ചയായിട്ടും.
The second case, it's a case of 36-year-old second gravida at 36 weeks, 6 days, referred with acute onset breathlessness as a suspected case of peripartum cardiomyopathy bar amniotic fluid embolism. She became near miss on the same day of admission. She was discharged on the 24th day with an ICU stay of 5 days. And the diagnosis made at the time of admission was previous cesarean with placenta previa, 36 weeks, 6 days, overt hypothyroidism, acute onset dyspnea, Curie LRTA, Curie pulmonary edema, Curie peripartum cardiomyopathy. She was referred from a government tertiary care hospital in view of acute onset of breathlessness and cough with history of fever as a suspected case of Curie peripartum cardiomyopathy, Curie transient amniotic fluid embolism. The first pregnancy was a full-term cesarean section done for failed induction 6 years back. It was uncomplicated otherwise. The patient was posted for elective LSCS next day. History of fever, cough, and breathlessness was there since 1 day. On receiving the patient at the higher center, the patient was conscious-oriented, but she was dyspneic and orthopneic. Her pulse rate was 126 beats per minute with a BP of 101/66, SpO2 of 96% with 6 liter O2 on flow. Respiratory rate was 40 beats per minute. Chest showed bilateral coarse creps present. The CVS auscultation showed loud S1. Per abdomen, the uterus was term cephalic, relaxed, no scar tenderness with a fetal heart rate of 148 beats per minute. Patient was shifted to ICU, seen by the anesthesiologist. USG chest revealed pulmonary edema. Patient was put on NIV. Emergency cardiology consultation was done. The ECG showed sinus tachycardia with biatrial enlargement. Screening echo showed severe MS with mild TR, mild MR, moderate TR, mild PH, and biatrial enlargement. The impression made was acute pulmonary edema, rheumatic heart disease, severe MS. Pulmonology consultation was done. Bilateral coarse creps, LRTA with pulmonary edema. Advised IV antibiotics and IV hydrocortisone. Cardiology faculty discussion the next day, rheumatic heart disease with moderate MS, moderate PH with good ventricular function. Present worsening of symptoms due to LRTA. Started on Lasix and digoxin. Patient was on NIV. Started on injection ceftriaxone, IV Lasix, injection hydrocortisone, tab digoxin. Plan for elective LSCS after controlling LRTA. Elective LSCS plus sterilization plus bilateral uterine artery ligation and bilateral utero-ovarian anastomosis was done under GA on the 6th day of admission. She delivered a female baby of weight 2.3 kg with an Apgar of 9 at 1 minute. The placenta was low-lying and the LICA was moderate MSAF. Post-op, the patient was shifted back to ICU and was put on NIV, pulse rate of 86, BP of 88/58, respiratory rate of 26 with an SpO2 of 98%. Chest auscultation, there was fine crepitation. Patient symptomatically better. NIV changed to face mask on post-operative day 2. She had multiple fever spikes on post-operative day 2 and 3. Started on injection piperacillin tazobactam. On post-operative day 3, her HB was 10.2 grams per cent. Total count of 28,180. Platelet was 1.05. CRP was 56 and lactate was elevated. The blood culture and the urine culture were sterile. The high vaginal swab showed E. coli and the sputum culture and sensitivity, Pseudomonas significant growth. The patient responded to antibiotics, clinical status and the biochemical parameters improved. Oral Lasix and Visalon continued, shifted to HDO on 12th day. The baby was in nursery initially on ventilator for 2 days. In Korea, severe perinatal asphyxia, intrauterine myocarditis. Baby improved and given to mother side in postoperative day 14. Discharged on postoperative day 19 in a good condition. Baby on tab Lasix and as advised to review in cardiology OPD after 2 weeks. So the final diagnosis was G2P1L1, previous years with placenta previa, moderate MS with pulmonary edema with LRTA. Elective LSCS with sterilization with bilateral uterine artery and utero-ovarian anastomosis ligation under GA. The NEMS category was 1.2, that is pre-existing disorders aggravated during pregnancy. The adverse event was cardiac dysfunction in view of rheumatic heart disease. The NEMS criteria, the symptoms and signs showed breathlessness, orthopnea, tachycardia, tachypnea. The investigations showed abnormal ECG and echo, and the intervention was ICU admission for cardiorespiratory support, that is NIV.
open for discussion. I think this case also will start with the cardiologist. I'll stop sharing.
Thank you, madam. So this is a 36-year-old lady who had pregnancy 6 years back. I think that was uneventful. Pregnancy full-term delivery for failed induction 6 years back, uneventful. Patient was also asymptomatic, so no way to suspect any event till that period. Patient suddenly had breathlessness. Probably at that time, patient had fever. So one is acute breathlessness. We have cough and fever. We suspect either a respiratory infection or a cardiac problem. Acute dyspnea, if it is a cardiac problem, maybe a left heart failure. So acute dyspnea, if it is a cardiac problem, left heart failure or sometimes pulmonary embolism. So if it is left heart failure towards the end, it is natural to suspect a cardiac peripartum cardiomyopathy because it is the towards the last month of pregnancy. So we can consider a heart failure, a transient amniotic fluid embolism. Okay, so such situation we have to evaluate further. So a patient having acute dyspnea anyway, we have to evaluate. Evaluation includes a respiratory evaluation as well as cardiac evaluation, and the biomarkers may be a BNP, which can show a, if it is positive, significantly elevated, it is heart failure. BNP may be useful in such situation. X-ray we may not take. ECG is useful to look at atrial enlargement and arrhythmias. So the patient was clinically examined, and good thing that this person who has examined, the doctor has examined, has picked up loud S1. Loud S1 definitely in a patient with dyspnea, this age group, we have to suspect mitral stenosis. So as Shekaran sir was telling, a proper auscultation is definitely done. I will add one more point. Any patient, you should auscultate the patient supine and is also in the left lateral position. Otherwise, with the cloth, even the cloth removed, not over the cloth. And otherwise, we will miss these findings. Even the reasonably experienced cardiologists also miss these findings if they are not, the patients are not examined properly. Patient should be lying down, and even in the left lateral position, you have to examine all patients with dyspnea, look for S1 as well as mid-diastolic murmur, because mitral stenosis is a problem in our part of the world, and we have to suspect mitral stenosis in all patients with pregnancy and dyspnea, which can be very problematic. So this patient had loud S1, and an echo was done. Echo showed mitral stenosis. So the diagnosis was immediately made and showed severe mitral stenosis. So from that part, how to manage mitral stenosis? Mitral stenosis produces a obstruction from LA emptying to LV. So the LA pressure is elevated. When the LA pressure is elevated, pulmonary venous pressure is elevated. Patient develops pulmonary venous congestion, and the patient develops pulmonary edema. The factors which worsen a mitral stenosis is increase in the heart rate as well as increase in the intravascular volume. Only two things worsen mitral stenosis acutely: increase in the heart rate and increase in the intravascular volume. Increase in the heart rate can be an arrhythmia like atrial fibrillation, or it can be because of sinus tachycardia, because of drugs, because of infection, or any other reason which produces sinus tachycardia can produce a problem. Any increase in the intravascular volume can produce pulmonary congestion. The increase in intravascular volume can be because of the natural increase in intravascular volume cardiac output of pregnancy, which manifests by the end of second trimester or during delivery, where the patient becomes symptomatic, or maybe because of increased IV fluid administration. So increase intravascular volume and tachycardia precipitates even in a mitral stenosis. So this patient was towards term, and there is an increase in intravascular volume, and there was a fever and respiratory infection, and subsequently it was proved by a positive sputum culture also that raised count that patient had a respiratory infection. So that produced tachycardia, and this tachycardia as well as the increased cardiac output of the pregnancy precipitated the events, and patient went into pulmonary edema. And when a patient develops pulmonary edema and mitral stenosis is diagnosed, the management option is to reduce the heart rate. So heart rate increase produces pulmonary venous congestion. Reduce the heart rate. Whatever way, we have to reduce the heart rate and reduce the intravascular volume. So we give a proper position because it reduces the venous return, and it also give diuretics in the form of ingestional acids, And we try to reduce the heart rate by giving different drugs. The drugs which can reduce the heart rate is digoxin is useful, especially when the patient is having atrial fibrillation. When the patient is having sinus rhythm, digoxin is not useful in reducing heart rate. Beta blocker is a very good drug to reduce the heart rate. So in a patient with pulmonary congestion with mitral stenosis, beta blocker is extremely useful to reduce the heart rate. And so diuretics, proper position, a beta blocker therapy to reduce the heart rate can stabilize the patient to some extent. And then if the patient is not stabilizing, if the patient is continuing to have severe dyspnea, probably we may even go ahead with a balloon mitral valvotomy or opening of the mitral valve. But this was noted in this situation. This patient was stabilized with medical therapy. Then to tide over the patient's respiratory problem, ventilation and non-invasive ventilation, which may be useful in a patient with pulmonary edema, was also given. So subsequently, the patient, what happened? The patient, I think, planned for cesarean section, and cesarean section was done. And again, there is a discussion whether we should go ahead with cesarean section, because as discussed in the previous situation, the fluid changes and hemodynamic changes does not
So this was a case of previous years, so we'll go for CS only.
Oh, okay. That was the indication for
previous years.
cesarean.
Yes.
So immediately after, immediately after cesarean, immediately after delivery, what can happen is we all know the hemodynamics with uterine contraction. Rapidly, the blood volume come back with each uterine contraction. Rapidly, the blood volume come back to the systemic circulation. So mitral stenosis patients do not tolerate this rapid return of fluid or blood from the uterus. So they can go into pulmonary edema at that time. We have to anticipate. So probably we may have to give diuretics again, proper position. And sometimes we give physiological venesection also for a short period. What is physiological venesection? We tie tourniquets in the lower limbs and the upper limbs for a short period to reduce the venous return. So that can, to some extent, mitigate the venous return or the reduce the intravascular volume. So maybe these measures are useful to reduce intravascular volume, and patient's pulmonary congestion can be relieved. So this patient was delivered with cesarean section, and postoperatively patient was managed with NIV. The heart rate was 86. Still, the heart rate of 86 is on the faster side. In a patient with mitral stenosis, heart rate of 86 is on the faster side. I would like to reduce the heart rate to even to 60 or 70 or near 60. So that will be better. We may give drugs like beta blocker to reduce the heart rate further. The patient had crepitations and patient had respiratory infection, which was managed well by the pulmonologist, and the patient improved. So here the patient had significant mitral stenosis, which was precipitated at the near term. And this is the time when either end of second trimester or towards delivery, that is the time when patients go for pulmonary edema. And the management will be to reduce the heart rate, usually by giving beta blocker, reduce intravascular volume by different methods, by diuretics or proper position water method, and then probably NIV. And if nothing works, then we may have to go for emergency balloon mitral valve.
Thank you, sir.
I don't know whether I was too long. Probably rather than me talking long, probably we can
you are
have
just
a discussion.
correct.
We're just apt.
Yeah. Again, I want to emphasize upon what Prasanna Kumari madam said, because she had a previous cesarean section and she had a normal delivery. She had undergone ANC twice, and during all these antenatal visits, she was not diagnosed to be a case of mitral stenosis. So that emphasizes how meticulously we have to. So how meticulously we have to examine the patient in the first antenatal visit. The first antenatal visit is the most important antenatal visit, where we have to take a detailed history and examine the patient fully, and then categorize her into a high risk or low risk patient. And then if we diagnose a murmur or auscultate systematically, and then if we suspect, then we should have a cardiology opinion in all patients with symptoms or any signs, so that we can manage her more effectively.
Dr. Sangeeta?
Yeah, I also agree that I feel it's a sad thing that her murmur
Yes.
was missed. At
Not detected.
126 pulse rate, when she came, if you can't find a murmur, it is very easily because the heart rate is far too high. There's hardly any time in between for you to hear. But when she came, when she was stable, when she came for antenatal care, that is the
Yes.
time it should have been auscultated and found out. Maybe
Yes.
you would not have, you would have started her on some form of treatment, but you may not have done anything actively, but you would have known that she's a case of heart disease, should have come for more frequent care. You would have treated respiratory tract infection much more aggressively right in the beginning. You would have put out warning signs on your OP card saying, beware of tachycardia, beware of excess fluids. And therefore, I feel that was really the miss in this case. And just one, this is a small thing. If there are any students in the amongst the parties amongst the group, when we were on postgraduates, we were taught when you have a patient who comes with acute dyspnea and mitral stenosis, you must think that it is pulmonary edema.
Yes.
And we had one mnemonic which our cardiologist used to teach us, LMNOP. L is Lasix, M is morphine, N is sodium restriction, O is oxygen, and P is a propped up position. And yes, sir had said very clearly two things. One is you must bring down the heart rate. Beta blocker is the best. And in some cases, if you also want to reduce the afterload as well. But in this patient, she came in florid failure, and that was precipitated by the respiratory infection.
Infection.
So
So
again,
one thing is, yeah.
auscultation very early in pregnancy as a routine. I think not just auscultation, pulse, blood pressure, and today we've learned that we should take the SpO2 as well.
Yes, 1 minute pulse, you have to palpate the pulse for a full 1 minute and see whether it is regular and what is the volume. I think both hands also you have to palpate the pulse to find out any other deviation. One thing is that in the antenatal period, if we had detected, as Sir said, we usually start them on metoprolol because so that the tachycardia will be prevented in the antenatal period itself. Then we'll have to correct the anemia aggressively, which induces and also induces tachycardia. Also that aggressively to restrict the physical activities so that she will not become symptomatic. These are the few things which you can tell the patient so that the complications prevented. And in the first trimester, if we detect a severe MS, and even in the second trimester, around 16 weeks also, we can do a balloon mitral valvuloplasty very safely. So that in the third trimester, she may not go in for such acute complication.
മാഡം ഒരു ഡൗട്ട് ചോദിച്ചോട്ടെ മാഡം കേക്കാം മാഡം
കേക്കാം
ഈ കേസില് ടെർമിനേഷൻ വാസ് ഡൺ ഓൺലി ഓൺ ദ 6th ഡേ അതെന്താ
സിക്സ്ത് ഡേ എന്ന് വെച്ചാൽ when you terminate a pregnancy within the presence of infection, that is a source of septicemia. So infection anywhere in the body can produce a septicemia. That was the reason that it was delayed a bit.
അല്ല മാഡം ഇത്രയും ഹാർട്ട് റേറ്റ് വരുമ്പോ there is a chance for decreased cardiac output.
But if she had improved
formation ഒക്കെ ഇല്ലേ മാഡം?
Actually, she had improved. That's why we waited. Otherwise, in case of acute severe cardiac failure, is an indication for emergency cesarean section. So actually, by cardiology management, she had improved. So we waited a little.
But when you're faced with an acute pulmonary edema, you first tackle the pulmonary edema, get her stable, and then take her up for CS.
Then take her up for CS.
Hemodynamics post-delivery will precipitate the failure more. And if at cesarean section, sometimes you are faced with those situations where at the time of cesarean section, she goes into pulmonary edema. Sir had said so correctly that you're using the tourniquets. When we were undergrads or postgrads, we would just press the IVC at that time so that the heart is not loaded further at the time. So your anesthetist tells you she's in failure, her lungs are wet and she's in failure. At the time of cesarean section, just press the IVC, the preload will decrease.
Shekharan sir and Shyamala madam are there. Before we go to Prasanna madam's concluding remarks, sir, Shekharan sir, what is it that you want to say?
No, I think the murmur in mitral stenosis is the easiest one what we can pick up.
Yes.
See, this is a very easy one. We may miss the aortic incompetence murmur. It is very soft murmur. You have to make the patient lean forward and auscultate. Here it is very rumbling what is the qualifications which we were. And so it is easy to pick up. So it again shows we are not routinely auscultating for murmur or any abnormality. That is one thing. If you detect mitral stenosis severe type, according to the either the severity by the diameter of the mitral valve and other thing, there is a place for correction of the lesion before pregnancy if we diagnose, or during pregnancy if she is having symptom, and after correcting it, there is a place for mitral valvotomy, so percutaneous, and then improving the situation. Otherwise, she will go in for repeated failure also. So these things we should know a little bit of cardiology or medicine, keep it in mind. And when we are looking after such patient, we must be knowing the basics of physics, the heart disease also. So that's why we are getting the help from our colleagues, but we should also know that everything referred to cardiology is not known. We have to know something acute management of a failure or pulmonary edema, we know. So like that, this case illustrates how efficiently we can treat even though we missed it early. So that is again a lesson, don't miss such gross things. It's a gross thing. Mitral stenosis is a gross thing, we should not miss it.
Unless we auscultate in the left lateral position, on the supine position, sometimes we may miss. So, sir, as sir said, a very good examination, patient lying down, and if preferably in the left lateral position, we should carefully auscultate.
Yeah, right. Sure. So if there is any suspicion, we should be more careful to. If I said that usually mitral stenosis murmur will not be missed. That was my point.
Yes, sir.
Shyamala madam? Shyamala madam had put on the camera. Shyamala madam, you want to say something?
I am not getting the, can you hear me? I am not getting the, cannot speak. I don't know what happened.
No,
Madam,
we
we
can
can
hear
hear
you,
you.
madam. We can hear you.
We can
Can
see
you
you.
hear me? Some problem, okay, I don't know.
ഇല്ല,
Can you hear
കേൾക്കാം
me?
madam, പറഞ്ഞോളൂ.
yes,
കേൾക്കാം.
Madam, പറയ്.
You want
No, I was listening from the beginning itself and studied so many few things also. Because everything was discussed normally, everything was discussed properly, but the importance of history taking, first it's difficult for you to take a detailed examination, history taking, and divide the patient into low risk or high risk. It's very important. We usually give high risk patients a different color antenatal card. So from that also I can say this is a high risk patient, we need more care and more attention and more importance in the OPD. You see, most of our postgraduates are coming into the OPD without a stethoscope. That is what I noticed recently. They have no stethoscope because the fetal monitor is there. They just put the toco and see and hear the FH. That is all. They have no stethoscope also. I'm wondering then how can they auscultate the heart, all these things. It is, it is, I think it is antenatal care and examination is coming deteriorating compared to the previous days. That we have to improve. That is the only thing I want to say. And then in our setup, we routinely refer all the patients above 30 or 35 years to the cardiologist routinely for an echo and cardiology consultation and echo. And all patients having some heart disease is always seen by the cardiologist also. Every antenatal visit is referred to the cardiologist also. It is not a combined obstetric clinic, but they are seen under the cardiologist regularly also. These are a few things I want to add. Then routinely, because when we discuss the cesarean section in a heart disease patient, previously we always used to say that vaginal delivery is always better compared to, now there is more, the importance of all these mechanical ventilations, all these has come. The hemodynamically patient can be better controlled when you give a cesarean section because the whole system is the anesthetist and cardiologist and they can do it. When the patient will put for a vaginal delivery, it suddenly collapses, they are not in a position to control the take back the patient. So better management and better monitoring and better this will be when a patient is having a general anesthesia when you do cesarean for critically ill patients, not rather than a vaginal delivery. These are few things that is all thing better. So some cases we may say vaginal delivery prefer to cesarean section over vaginal delivery because better hemodynamic control will be when the patient is under GA and we can continue ventilation and we can gradually taper the and bring out the patient from anesthesia.
Madam, thank you so much. ഞാൻ പറയുന്നത് PGs കൺസൾട്ടൻസിന് അടുത്ത് ബോറോ ചെയ്യും സ്റ്റെതസ്കോപ്പ്.
ഞാൻ ഈയിടയ്ക്ക് നോട്ട് ചെയ്തന്നെ none of our postgraduates is coming with a stethoscope. ഫീറ്റൽ ഹാർട്ടിന് ഡോപ്ലർ വെച്ച് ഫീറ്റൽ ഹാർട്ട് കേൾക്കുക തീർന്നു. Ultrasound നോക്കുക, no palpation. And as I say, this is coming down, clinical examination. That is why we are missing all these cases.
Madam, there are certain questions in the chat box.
അതെടുക്കാം സർ. പ്രസന്ന മാഡത്തിന്റെ കമന്റ്. മാഡം കൺക്ലൂഡിംഗ് റിമാർക്സ്. ഡോക്ടർ ജ്യോതി is also there. Jyoti will come to you after Prasanna madam. Prasanna madam.
Let Jyoti speak, then I will conclude.
Jyoti.
Jyoti.
Respected seniors and faculty, a very lively and important discussion. I just want to share three things. Last MDNMSR meeting, we had two cases, and we understand that with IVF treatment, women are getting treatment beyond 35 weeks, 35 years. So we had two patients who were, one was married 14 years, one was 33 years. This 33-year-old had a congenital heart disease with double outlet right ventricle who had a patch. She went for IVF treatment and conceived twins. And at 29 weeks, she went in for heart failure and we had to do a CS and then she needed a ventilatory support. So I would just would like to tell that all the fertility specialists, I think they should do an echo on elderly women who are undergoing IVF, whether they are fit to carry the pregnancy, and if it becomes twins, definitely the risk gets doubled up. Another woman who was having tight mitral stenosis of 0.6, she was not diagnosed, she was not auscultated in the antenatal period, and 33 weeks she comes with failure. So that these are the two cases which we had last month, and that's really an eye opener. And another thing is that our institution is part of our NPAC study, that is National Pregnancy Cardiac Disease Study. This study is being done at 56 centers all over India. And it is a 4-year study. In the first year, Dr. Justin Paul is the principal investigator. In the first year of the study, we just try to find out what is happening in each of the institutions, how they are managing heart disease, how they are what are the incidence of failures. And in the second year, it will be a cluster randomization study in which half of the centers will continue the same care and the other half will be given a protocolized management. So the study will take time, but then certain important things we had in our meeting was definitely that we should put in a mark or something on the OP ticket or the IP case sheet so that the patients, the heart disease patients can be easily identified. And secondly, as we said, all high risks should undergo an echocardiogram so that this can be avoided. And in certain centers, actually in our centers, we never had any valve thrombosis, but there are centers which had huge amount of valve thrombosis with valve replacements. So they have also recommended that they should start a thrombosis clinic where the women, they don't adhere to your warfarin doses, so which can be told to them. And then there is some change in the management where you can antenatally do the valvotomy around 26 to 30 weeks. Earlier we used to say second trimester. So I would like Dr. Sibu to just something about interventions in
chat box. There is a question. I think we'll come to that later about surgery in mitral stenosis. Prasanna madam, you want to talk now or after Dr. Sibu addresses the question?
Whatever it is, Dr. Sibu,
Madam പറഞ്ഞോളൂ. Prasanna madam, you say your comments. അത് കഴിഞ്ഞിട്ട് ആ ക്വസ്റ്റ്യനിലോട്ട് പോവാം. What do you want to say about this case?
as has been already pointed out, the history taking should be complete and examination should be complete. And we were taught by Mathroy sir to auscultate the patient if there is doubt, or if we find that there is tachycardia or some symptom of mitral or heart disease. Patient should be looked, mitral stenosis murmur should be looked for in the left lateral posterior. Rough and rumbling mid-diastolic murmur with pre-systolic accentuation and a loud first sound. When there is tachycardia, this murmur will not be appreciated. That is the problem. If patient previously, if she had been examined, definitely would have picked up the murmur. That's what I feel. And another thing which I should appreciate in this patient is that the management, the sepsis markers were done, and when they found that it's elevated, she was started on piperacin tazobactam, and the organism was Pseudomonas. And otherwise, if that has not been attended to, she would have died of sepsis. So last CRMD, there were 2 patients. One was sustained a depressed fracture of the temporal bone, and she died. She died of sepsis. Sepsis was not attended to. And another patient who had a Arnold-Chiari type 1 malformation, which is there ever since her birth, and that was attended to by the neurologist, and then she died of sepsis, and sepsis was ignored. So this patient sepsis was attended to, and piperacin tazobactam was started. It was Pseudomonas, and she responded. Yeah, and of course, ND probe has been emphasized by cardiologists as a marker of cardiac failure. And emergency balloon myeloplasty, if it is deemed necessary, like this patient, 3rd trimester, it can be done, isn't it, Dr. Sipu?
Yes, madam. It can be done.
Can be done.
So
If it is needed, it
emergency.
can be done.
So the decision you should.
She goes
Yes,
for
madam. Continue,
repeated
madam.
pulmonary
Continue,
edema.
madam. Yes. Can be done.
Yes.
The
And
question is, can
everybody,
surgery be done in pregnancy with mitral stenosis?
I have not
Chat box
finished, Lakshmi.
question.
I have not finished, Lakshmi.
Okay, madam. Okay, madam. Continue. Because you are in between.
When
That's
somebody finds the patient in typical pulmonary edema, frothy red bloody sputum, and all sounds in all the chest lung fields, and they should the obstetrician should know how to treat pulmonary edema. We have been taught by Mathroy sir, MAO DDP, morphine, aminophylline we don't give now, oxygen digitalis also we don't give, diuretic and physiological venesection. Morphine is a wonder drug, and I think morphine should be given in a small dose, maybe some 2.5 or 5 milligram, because we should be watching for hypotension when we give morphine. It diverts the blood to the periphery. It's a dramatic drug for treating pulmonary edema. And I agree with Sangeeta that in a hemodynamically stable patient, stable patient can be in hemodynamically stable state when you take her for section. Especially if she has a very tight mitral stenosis and she is in failure. She had gone into failure. It's better to have to take her for section under general anesthesia, because there is somebody to monitor control the hemodynamics. So that is, so my concluding remark is that everybody should take a proper history and a proper examination. And if you are suspecting mitral stenosis, auscultate in the left lateral post. We have done it several times in the ward as a final year student under Mathroy sir. Sir used to say, and we used to auscultate in the left lateral position. It will be very clearly heard. When there is tachycardia, of course, we may not be able to hear it. And always when you manage managing tachycardia is a very important aspect of this mitral stenosis. And beta blockers and emotional stress also should be avoided. Physical and emotional stress should be avoided to reduce tachycardia. Thank you, Lakshmi.
Madam, Ishak, thank you. Shamala madam, you want to say something else?
Nothing else, you should stress on pre-pregnancy counseling. Because every chance you get to just tell the patients before pregnancy, come for a pre-pregnancy checkup counseling. So all we can exclude all these things. That also should be included in our therapy.
See,
Pre-pregnancy
myself,
examen.
in our hospital, I won't see the patient unless the PG examines the patient completely, including every system, breast, thyroid, everything. Whether the patient comes for annual checkup or with discharge PV. I ask them to completely examine the patient and then only I will see the patient. Let them do the specular examination, biomanual examination, then only I will see the patient. They are here with me, they are laughing.
The PGs are coming with a stethoscope. Our PGs are coming without stethoscope. So I have to let them out.
Show your stethoscope.
But we very rarely we get patients for pre-pregnancy
Unless
counseling.
they auscultate, whether it is discharge PV, unless they auscultate, they see the breast, thyroid, abdomen, spleen, liver, everything. I will not see the patient. Let them completely examine the patient. Then only I will see the patient. Okay. They are all laughing.
It is excellent, madam. That should be the way training should go. That's appreciations, madam.
We are very strict.
Sir, ഈ പേഷ്യന്റ് ഇനി എന്ത് ചെയ്യും? അപ്പം വാൽവുലോപ്ലാസ്റ്റിക് ചെയ്യോ sir?
Basically, we have to assess this patient's mitral stenosis post-pregnancy. Once the hemodynamics blood volume has settled down, we have to do the echo, and there are certain criteria. So if the patient is having significant mitral stenosis of mitral valve area less than 1.5, patient was symptomatic, and valve is suitable for balloon mitral valvotomy, we can do balloon mitral valvotomy. And otherwise, mitral valve replacement, we wait a little more because we are not ending the problem. We are transferring the problem to another situation. Prosthetic valves where the patient may need long-term antithrombotic therapy, all those things. So if balloon mitral valvotomy can be done, we may go ahead. But that depends upon the complete echo assessment. I don't have the entire picture with me. We are with what is the valve like, what is the calcification, what is the valve area. So it depends. So anyway, the patient will be on diuretics, patient will be on beta blockers, and subsequent pregnancy we will give caution, and we will assess the valve. And if the valve area is significantly stenosed less than 1.5, we are likely to go ahead with the balloon mitral valvotomy, and sometimes balloon mitral valve replacement.
Thank you.
So one more doubt regarding the previous patient. Previous patient of primary pulmonary hypertension was a primary-gravid patient. Would you, what would be her future pregnancy prospects like? Will
be higher risk because anyway, the patient has significant dilatation of the pulmonary arteries and PA pressures are elevated. So this person will be having a high risk for future pregnancies, and we will advise against future pregnancies. We'll be putting the patient on specific drugs like PH drugs, specific drugs. Post-delivery, we can be put on ambrisentan or bosentan. That is safe.
So that was she is now on that drug.
With that, we will assess the pulmonary artery pressures. Most likely, the patient will be having problems in the subsequent pregnancies. Also, will be advising against.
So she need to be on a long-term contraception, right?
Yes, yes. So what type of contraception? Anyway, that also which may not produce.
The literature says that the progestin-only contraceptions would be safer. Yes. Maybe LNG-IUS or something like that.
Long-acting depot.
Long-acting depot or
long-acting reversible. Okay.
We can give
LNG also. LNG-IUS
or
also
Marina.
is recommended, madam. Marina
or Implanon you can give subdermal.
Yeah. Yes, ma'am.
There is a single rod Implanon is now available.
Okay.
There's some questions on the chat box about the previous one. Sir has already answered. If yes, what are the can surgery be done in pregnancy for mitral stenosis? If yes, what are the indications of surgery? That sir has already said. Now, should we take BP in both hands?
Yes, definitely.
Coarctation.
The BP should be taken in all persons, both hands, and the higher BP should be the BP, and that limb should be used for measuring the BP subsequently. That limb.
And another thing I want to say about the size of the BP curve. So for obese patients, you have to use the larger, otherwise you won't get the right. That is also a problem now. Unless you have that large size curve, you will get a wrong reading.
Yes, madam. Yes, madam.
Now, what age can be taken as a cutoff for echo?
We cannot tell like that. There is no recommendation. There is no international recommendation for age-related echo.
As Madam
But
said,
we do it roughly for those above 30 or definitely above 35. We refer to a cardiologist for a routine echo. So there would be no surprise during pregnancy, no?
one more question. Do we need to do echo routinely in third trimester?
Right.
Already answered.
No. Not for all patients, only elderly patients you do.
Okay.
There is one question: if there is mild MR and mild TR, echo is usually certified normal. Mild MR and mild TR is very often seen in very large number of persons when we do
Normal pregnancy.
normal